Hello, I'm Beverly Phillip, and I'm honored to be able to join you for the 2020 IAAS virtual meeting. And I'd like to share with you some perspectives on ambulatory surgical care and COVID from the United States. Let me start with the US timeline. We had our first confirmed case in January, and by mid-February, our first community transmission. By early March, it became clear that COVID was becoming a nationwide epidemic. And our government acted. The president declared a state of emergency, and CMS, which is the National Government Healthcare for the Elderly, issued guidance to limit all non-essential planned surgeries and procedures until further notice. And the professional organizations responded. First, the American College of Surgeons issued guidance about managing elective procedures. And because this is a multidisciplinary need, ASA, the American Society of Anesthesiologists, joined the surgeons and the operating room nurses to issue guidance about a surgical review committee to conserve surgical resources. Well, this is a graph of the COVID resource needs in the United States, real time, as of mid-April. We all expected there to be a surge of cases, and then we'd be done with the disease. So by mid-April, we saw we were passing the peak. And because of the impact on patients who needed deferred care, as well as the impact on the healthcare economy, many thought about how to resume non-essential but needed surgery. But we needed to do this safely. So by mid-April, working in parallel, the federal government and major professional organizations offered a series of expert recommendations, and this is what I'm going to be going through with you today. I think the biggest and first of these was a roadmap about resuming elective surgery after the COVID pandemic. And this was a joint collaboration of the American College of Surgeons, the Society of Anesthesiologists, operating nurses, and American Hospital Association. And I have to say, this cross-disciplinary collaboration simply had not been happening before COVID. But this is what, working together, we came up with. We should be guidance, a roadmap to resume elective surgery when there was sufficient personnel and resources to avoid a crisis standard of care. And what a crisis standard of care means, when you can't do what you would usually do, where you are deviating from what is your usual best practice. That to resume elective surgery, we need to consider testing, if it were available for patients and staff. We needed personal protective equipment, PPE, adequate for the planned types and numbers of operations, and we needed a prioritization policy committee consisting of multidisciplinary leaders with objective criteria. We recommended that institutions need to develop policies on how to address the entire arc of perioperative care, pre to post, with issues specific to COVID, reassessing health standard, directives, post-acute care. We needed to address data collection and management, safety and risk mitigation, healthcare worker well-being. And I want to point out, take a pause, that all of these documents are available from the American Society of Anesthesiologists. They're publicly available on the ASAHQ website. Just search there. Now, in parallel, our CMS, National Health Insurance for the Elderly, offered their recommendations. And they had a series of very high goals of very low local COVID coincidence, setting up non-COVID separate care zones, having everyone wear face masks at all the time and conserve them, facility decreasing patient volumes to allow distancing and testing as for patients and staff. These were really high goals, but none of this was actually possible because we did not have the supplies or the physical ability to follow these guidelines. So instead, our professional organizations provided more real-world guidance. This is from the ambulatory community, the Society for Ambulatory Anesthesia, that issued a document about resuming ambulatory anesthesia care as our nation recovers from COVID. And they offered some real important pointers that in ambulatory care, we needed to develop a stepped approach for reopening ASCs and other outpatient facilities when there was a low incidence of COVID admissions to regional hospitals, trending decrease in cases, and adequate PPE. And they specifically warned, be cautious in performing surgeries that have the potential for patients needing to transfer to a higher level of care. Start with lower risk, shorter procedures, and then go to more advanced ones. And I think this organization led the movement to point out we now had new options that we could and needed to explore for remote preoperative evaluation by anesthesiologists using telemedicine platforms. ASCA is the Ambulatory Surgery Association, and they are the industry group representing ASC interests to government, regulators, and payers. And they were proactive. Going into the epidemic, they issued a statement encouraging their member ambulatory surgery centers to postpone elective surgery, to be prepared to take on cases from hospitals or volunteer their facilities to contribute to the community healthcare. And they provided concrete guidance, tools for ASCs to record the resources and capacity they had, including items such as what staff, what equipment, what capacity. As we started to resume elective surgery, ASCA issued another guidance to guide that ASCs should resume deferred elective surgery, elective but necessary surgery, if the community prevalence of disease was low or declining, and the community had sufficient bed capacity and PPE for the care of the COVID patients that was still needed. And that ASCs, as a second major point, ASCs can provide safe care. They have to consider screening patients and staff, following government recommendations, distancing, masking, and adequate disinfection. And I think from even a larger sense, provided great guidance, looking to the community guidance about surgical care, looking to patient prioritization, starting with patients with lower comorbidities and surgical risk, procedure prioritization, starting with procedures that have less risk of airborne transmission, less risk of hospital admission, and testing where feasible. And as they, again, here too, provided concrete checklists about helping to reopen your ASC and about emergency response expansion. Another problem we had during the pandemic was an issue of drug shortages. This is a chronic issue in the United States, but was greatly worsened during the pandemic because of drugs largely needed for the intensive care and also disruption of our international supply chains. So the American Society of Anesthesiologists worked together with the Organization for Health Systems Pharmacists to provide a multidisciplinary guidance document. Several major points: infection prevention and control, that while we need to continue to emphasize infection prevention, don't discard unused and open medications, especially those in short supply. There are other ways to do it. Put these drugs separated aside, for example, in plastic bags that you could disinfect the outside of the bag and then conserve the drugs for another patient. They issued We issued guidance on medication storage policies, to use of literature to support longer dates before expiration beyond what is on the vials, and to allow compounding pharmacies and other facilities to prepare other drugs if they are needed in shortage and for hospitalized COVID patients. Another ongoing issue during COVID was the availability of PPE for anesthesia professionals. This has abated somewhat, but continued to be a problem throughout the pandemic, and in fact consists today. This is an updated document, first in April, now here in June, because the problem still existed. The issue was that hospitals were not providing adequate PPE for their anesthesia providers. They didn't have it, but what they did was tell the providers that they didn't need it. And the anesthesia professionals who were working in the airway bought their own approved PPE, and some facilities forbade them from using it because it might frighten the patients. Some anesthesia providers were disciplined, a few were fired. So our organizations came together to promote patient safety. And here we have an organization across the spectrum of anesthesia providers in the US, the American Society of Anesthesiologists, the Organization for Anesthesiologist Assistants and for Nurse Anesthetists, and the Anesthesia Patient Safety Foundation. The points we made were that the safety of anesthesia professionals is of utmost importance to developing policies related to PPE. If you don't have a healthy workforce, the work will not get done. Our recommendation was that all professionals had now a document to support they needed to utilize appropriate PPE during aerosol generating procedures for all patients. Endotracheal intubation, any work in the airway is going to be an aerosol generating procedure. Next point, that the facilities should issue N95 masks or equivalent equipment for all anesthesia professionals as a facility priority, and that understanding that conservation is important. Healthcare facilities may wish to implement extended use or limited reuse practices even before shortages are observed, so that adequate supplies will be available when peak need and demand occurs. And of course, using these N95 masks in unusual crisis care modes should follow the best safety guidelines. Now, over May and June, we organizations developed experience working in the COVID world. And it became clear to all of us, as it did to you, that COVID is not going away. So we needed to reframe our approach to the care of the COVID patient. Now we are talking about maintaining essential surgery during an ongoing COVID pandemic. This is where we're going to be for quite a while. And here, this document, again, an unusual collaboration between the American Society of Anesthesiologists, because we actually were the organizer of these events, and I was the drafter of them. And it's the American Society of Anesthesiologists with the surgeons, the operating room nurses, and the hospital association. What we had learned about our pandemic was two major overriding issues: that regional cooperation was critical to providing essential surgery, tying in with supply chain issues. And this regional cooperation needed the hospitals, the medical professional societies, and the government agencies to make it work. And we needed to consider the breadth of everything that we needed to care patients correctly. So we needed hospital facilities, ICU and non-ICU beds, PPE, testing reagents and supplies, vital equipment, medication, and again, to emphasize, sufficient trained staff. On a more concrete level, beyond these two umbrella issues, we addressed that facilities need to have developed guidances about COVID testing within the facility. We now this knew was a matter of patient safety. We already had seen all the reports that if patients have surgery during undiagnosed COVID disease, they have bad surgical outcomes. So testing was a patient priority. And now as testing equipment was becoming more widely available, many facilities now are testing all patients before their surgical care. We also needed to address testing of hospital staff because staff are exposed in the community, and we need to prevent transmission within the healthcare facilities. This joint statement promoted consideration about PPE, because there's still shortages of PPE, roving shortages, with policies for conservation, extended use and reuse, policies for case prioritization and scheduling, and timing. When are we going to do these extra surgeries? Evenings, weekends, and specific detailed policies for the care of patients during all phases of surgical care. Now, we specifically addressed the need for pre-assessment because we had become aware, all of us, that COVID was not only a lung disease, but affects every major organ system, from kidneys and heart and brain, and the effects are not only acute, but can be long-term and chronic. Pre-assessment as a major factor. And we also recommended that facilities address policies surrounding surgical care for the patients, for the personnel, about OR turnover, about cleaning and sterilization, about facility management. We emphasize that facilities need to collect data about COVID so they know how to plan for their care and COVID-related safety and risk mitigation. And that brings us to one last point. All of the multi-specialties documents and all the societies were increasingly aware that the large issue here was healthcare worker well-being. In many of these documents, not only were we seeing increases in stresses and anxiety and burnout, but increases on how healthcare workers were coping with these stresses, not in the best way. Community-wide, not just healthcare worker, we have seen in the US increase in alcohol and drug use, increase in domestic violence and child abuse, and even more tragically, increases in suicide and especially healthcare worker suicide. So to conclude, these have been some ways the way the United States has approached resuming and maintaining ambulatory surgery as we realize that this is going to be a long-term COVID era. What we learned was that system-wide planning is critical. And we need to develop facility policies based on science more than on business interests and use the best available data. And that means that we're going to need to revise what we do based on new incoming available data. And the last major point that we really emphasized is that communication is key. We need to communicate to the public because they are all potential patients, to policymakers and payers, to industry partners and suppliers, and specifically to the healthcare workforce. All of us, because it is we who make the care of COVID patients possible in this difficult time. Thank you very much.